Well, good morning, ladies.
Good morning.
Good morning.
Oh,
And good
man.
morning.
Is
What?
that a fourth
What?
voice?
I know.
What?
So it's
Oh,
the
it's
heavens
laughing.
talking to us.
JJ,
Oh.
that seems so appropriate.
I will say this. Today's guest is, for us, it is something of a blessing because she has experience in something that we had experience in that
That's
was
true.
a blessing
Yes.
for us. So
Oh,
I'm
you
kind of,
just-
I
are you
won't
gonna-
say excited seems like an odd word.
It does
but
seem
I think
excited
it's
to be
gonna-
excited about death.
But
And
you have to
hospice.
plan for it.
Yeah.
And so
Who gets not many people get excited about hospice. They're not like, yes, let's do it.
but you have to understand it. So do I get to introduce the guest? Because
Do
now
it.
our listeners like, oh my gosh, well,
They're like, who is
What
this
it?
person? And Emily's like, will you all stop bantering?
Yeah.
Hey, good morning, Emily.
Good morning.
You
Can't get a word in edgewise with these two.
Let me tell you about who we have here with us today. It is not the angel speaking to us from above, her little voice in the background, because we're going to let her talk. If you don't understand hospice today, this is a podcast that you're going to want to listen to. There's so much more, but today we have Helen Bauer with us, and she uses her experience as a certified hospice and palliative care nurse and many years of experience as a hospice professional to inspire, educate, and foster connection. She hosts the Heart of Hospice podcast, which you got to listen to. We'll definitely have the links
It's a good one.
in our show notes, where she sheds light on the end of life experience and offers hope and encouragement to anyone who is navigating hospice and end of life care. Now, this is something that's brand new to us. We have not had a podcast like this. Her personal caregiving journey.
You can't make this up.
Yeah, I know. She was the medical decision maker for a close friend. Here's the interesting part. They never had any end of life discussions. And taking on all the decisions related to her friend's healthcare, living environment, and caregiving situation was, Helen says, a daunting task, overwhelming, and pretty frightening, even with all of her experience. Helen, it's your turn. We are so happy to have you here with us.
Yes.
Thank you for coming and joining us today.
Well, I'm so excited. I hope I can live up to the hype. This is a lot of pressure.
It's a lot of
It was
pressure.
a lot.
It's a lot of
There's a
pressure.
lot.
No, I'm so glad to talk with all of you. It's awesome.
Oh.
Go ahead, Natalie.
Oh, so Helen, normally we love to ask, tell us about your caregiving story, start from the beginning. Okay, so you were born and then skip all that part. And then,
Right.
But like, how did you, because you're a nurse, you're an RN, right?
Yes.
Okay.
Yeah.
And so clearly servant heart and caring for others has been ingrained, is part of who you are. And so, and then, I think there's a special place for people who, and I had an employee of mine who went to be a hospice social worker. And that's a special place because I was shocked when she wanted to do that because that's hard. Mortality rates are still at 100%. Everyone who is in there typically dies. And so how did you get into that? And then how did you get thrust into this caregiver role with, kind of like without, like, you didn't raise your hand and say, oh, I want to do it. They were like, hey, you're doing it. You have no free will.
Right. Well, the hospice thing for me, I'd been a nurse for quite a while, working in community-based care, and I had been raising my kids as a stay-at-home mom, and I just needed a full-time job. So for me, it wasn't, oh, I feel called or I have a mission. I'm not that nice, right?
Oh, that
not
is so
that benevolent.
Oh,
Yeah,
That's a heartwarming story.
that's endearing. That's endearing. And I had a friend that I admire and love. I'd worked with her before, and she said, hey, I work with this hospice team. We have an opening for an RN if you're interested. So I went over there and I thought nursing is nursing. No.
Wow.
Oh, wow.
Completely
Yeah.
different, completely different. Fell in love with it. And I knew at that point that that's where I wanted to spend the rest of my career. And if any of your listeners know anything about nurses, we job hop. It's the nature of our industry. It is just the total nature of the work that we do, because burnout is a high, very real issue.
Yeah.
And the hospice compassion fatigue is always a problem.
Yeah.
So I just found my niche, and I knew I wanted to work out the end of my career. So I've been in hospice now for 14 years, and I absolutely love it. Absolutely love it.
You say it's different. How so? Just because what is different for you compared to the original nursing that you did?
Well, when you work in a hospital, or even when you work in home health, the engagement with the patients is different. You don't get immersed in their family life. You don't take on all their myriad of issues. So, for instance, in the hospital, you have a controlled environment. You have your peers all working around you. There's this whole system, and the patients come to you. You may meet a few people in their family, but you just barely scrape the surface on that. You don't get drawn into their dysfunction or whatever they have going on.
Wow, no, dysfunction.
Dysfunction. That feels
No.
so good. Let's swim in that for a while.
Oh, man. So in hospice, that's exactly what we do. We go out into their homes, wherever they live, assisted living, nursing homes, private residence. We even see people who are unhoused on the streets, and we are immersed in their problems, their family issues, their family dynamics, their health issues. And most of the time, we treat all of their health issues. We care for the whole patient, mind, body, and spirit. So it's very easy to see how that is an overwhelming situation. I remember when I first started working in hospice, I would come home, and it was very difficult to describe to my husband. I said, these people are so sick. I have never seen anybody so sick. I didn't know you could have cancer in so many different sites. And it was very overwhelming at first. And also you have a lot of autonomy. When you're working out in someone's home, out in the community, you may be 30, 45 minutes from even your office where your agency is housed, and you are it. You are the person there. So it can be a little bit daunting.
So you said something that was interesting, and I think it may be a misconception as well. So you say, okay, hospice. And so I immediately think, oh, that really nice building that is funded and by, a local nonprofit. It's a really pretty building, and you go to hospice. Right. So you actually went out in the community.
Yes. So most patients in hospice are seen in their homes.
Really?
There are hospice facilities, but hospice is not a place. Hospice is a philosophy of care.
Okay.
That whole body care, whole person care. We also care for the family as well.
Oh, so it sounds very family centered.
Oh, absolutely.
And so, which is a different and when you think about especially around insurance and when people think about who is the client is not an individual. It sounds like the client is the family, because you cannot exclude the family who are their caregivers.
Right. That's even regulatory. We are charged with taking care of the patient, the person with the illness, and the family of choice, whoever they recognize as family.
So I know that we talked about, JJ had mentioned in the beginning where we talked about hospice and palliative care nurse. And we talked a little bit about this before. What's the difference? Because I don't know the answer to this. What is the difference between hospice and palliative care? Because I hear there is a difference.
There is a difference, and it's confusing, I think, even for a lot of people in healthcare. So palliative care and hospice are actually two different specialties, right? Palliative care is the new kid on the block. Palliative care physicians and palliative care medicine. That's a newer thing.
Okay.
Palliative care, to put it in its simplest terms, palliative means comfort, right? You're going to palliate something. You're going to relieve the symptoms. So in hospice, we do provide palliative care. We provide comfort care. Palliative care, as a specialty by itself, means that comfort care, that symptom management, but while you're seeking aggressive treatment.
Okay.
So there's the difference. There's the difference. So hospice always includes palliative care, but not all palliative care includes hospice. Now you see why it's so confusing.
That makes total sense.
Yeah.
Because you're not at a place where it's really more of a formal transitioning.
Right. You're not within that quote unquote 6-month window of being terminally ill.
Interesting.
Calling it comfort care helps me. That's a good term. It's palliative care, but it's comfort care. So that kind of that will help me to differentiate it in the future.
It's really not the best description of palliation, of palliative care, but it's the one that's easiest to understand. So that's the one that I use, because I'm telling you, even nurses, healthcare workers that don't work in the end of life space, they don't understand it either.
Yeah.
That's interesting. I think, I think about like how when Jason was sick, so Jason was receiving active treatment. Here's a question. He was receiving active cancer treatment last year. Would he have been potentially eligible for palliative care then?
Absolutely.
Not hospice. And so that's interesting because no one ever used those words, or nobody ever said, let's talk about palliative care while you're receiving oncology treatments. And that's interesting because I would not have known that. I think this is important. I know this is about caregiving, but this is important because as a caregiver, there are questions like when you don't know the right questions to ask, you don't know what you don't know.
Right.
And then it's not offered to you freely. Like, hey, did you know about this? No, I just assumed palliative meant when they were dying, and nobody wants to be like, no, he's going to survive. No, this is what it means. That's interesting.
Guys, do you remember, Mom and I did a study, I think it was at the University of Syracuse or somewhere up north. But they were trying to integrate a palliative care for people with Parkinson's. So we were just part of the study because they wanted to get it started for, as Helen's saying, like the whole person. So we were a part of that.
Yeah.
We were part of that. And it was just amazing, some of the options they were giving us. And it would totally be free. Mom has therapy. Actually, the caregiver has therapy also, just talking with them. But it was very unique. We enjoyed it while we were able to do it.
Yeah, it's a really great specialty. I just think what you were saying, Natalie, about people not knowing what they don't know. So how can you advocate for something that you've never been educated on or you've never heard of? So that's why I try to teach and educate, and I speak so that people are better caregivers. They're better advocates. Advocacy is exhausting for a caregiver.
Oh, yeah.
Yes.
Right?
Yeah.
Caregiving is exhausting as it is, right? So if you rely on your health team to tell you everything that you need, that's never going to happen. That's not real. So being an advocate and having to pull all those pieces in for yourself and then use them for the person you're caring for, that takes an enormous amount of energy on the part of the caregiver.
Yeah. It's and emotionally too, because there's a lot of things that are kind of put, I think, in front of your face, like whether it's hospice or palliative, there's still, even with palliative, and it's meant to be comfort. A lot of people don't want, like, well, I'm fighting. Like there's always the war analogy with especially cancer. Nobody's like fighting Parkinson's necessarily. My mom's living with Parkinson's, and we're, prayerful, hopeful, working towards a cure. But definitely cancer has this different fight term to it. I think that's used a lot more frequently, but I think a lot of people may associate the two terms together too closely and think, I'm not going to ask about that because then maybe I'm dying. And I think that could be that's very scary.
Yeah.
It's a very scary thing.
Yeah.
That's interesting. Well, and so go ahead.
Well, I was just going to say, a lot of people may have some curiosity about palliative care or curiosity about hospice, but they're hesitant to ask for information from their healthcare provider, physician, nurse practitioner, whoever they're working with, because they don't want them to give up on them and say, well, this person no longer wants this treatment. They're losing hope in it. They are losing confidence in it. So we're not going to bother with anything. A lot of people think that if you even talk about hospice or you elect hospice, you choose hospice, well, then you can't ever have CPR or you can't ever go back to the hospital, that it limits your choices and you're stuck with where you are. And that's not accurate either.
Man.
So,
Go ahead, Jay.
No, go ahead. I know you've got a question about what you said.
No, I was just thinking about palliative versus hospice, and then how long. I know that, again, this is a caregiver thing, but I think this is really important for caregivers because, and this is honestly, Helen, I'm assuming why you guys started the podcast, The Heart of Hospice, to really kind of educate folks about what this is in the same kind of way that we talk about caregiving, relate, educate, inspire, like, because the more well-informed you are, the better that you can support the person that you're caring for and yourself.
Exactly.
So
here's where it begins. So this is so unique to me. So you are, I don't know whether the word nominated, maybe it's drafted.
I think drafted.
Drafted.
Voluntold.
I like that better. Voluntold.
I'm writing that down.
You are now the caregiver for someone that you never had a discussion with end of life with, Helen. This is, and I know it's not a family member, it's a family friend. Yes. So I'm ready, because I know the way caregiving is, you never know when you're going to fall into it. But this is pretty interesting, Helen, that you're like, oh, it could have been a stranger. So what happened with this?
So this, she's since passed away. She has died. So the intense experience of caregiving lasted for about 3 months for me. We had a family friend, a dear friend of my mother-in-law's, who had been Aunt Betty, one of those friends like family, come to all the birthday parties and the holidays. She spent every holiday with us. She had no kids, had never been married, no siblings that she was close to. And several years ago, way before my caregiving experience started, she handed us a packet. In fact, I think she had my mother-in-law give it to my husband for us to store. So there was no direct contact or discussion about it. And it contained her will. It also contained a medical power of attorney document, naming me as her sole agent for all her healthcare decisions. And at the time, I really sincerely hope that we pulled it out of that envelope and we looked through it and said, oh, this is what's going on. My sincere hope, I don't remember, is that we didn't even see the medical power of attorney document, because several years later, after no discussion, no broaching the subject, nothing like that, we were called to the hospital because Betty was seriously ill. She'd been undergoing cancer treatment and she'd become septic. Struggling with a lot of depression. She'd become very isolated, had not tolerated her treatment well, things like that. And her quality of life had just tanked. And I knew all of this through my mother-in-law, who had kept in touch with her. So when Betty became septic, they took her to the emergency room, and we were called because sepsis a lot of times causes severe confusion, and she could no longer make her medical decisions. And so on the way to the hospital, and I will tell you, boys and girls, this is not the way to do advanced care planning. On the way to hospital, which was about 10 minutes away, my husband and I pulled out those documents and started looking at everything. No specifics, no diagnosis specific directives, nothing personal, just the document that said I was her agent and not another agent named, not an alternate agent. So wow. I began pulling it out of the air and figuring it out from there.
So how did you make decisions? Because I mean, if you've got an individual, I'm sitting there thinking about what's in my medical power of attorney, and JJ she was also voluntold. I'm like, guess who's in charge? But honestly, yes. we make JJ in charge all the time. My husband, she's everything for I'm sure Jason's brothers have my sister as their person. And so I'm like, we need an adult. So JJ's in charge. Even though on the screen, her name is Natalie. Good job, Jay. And so nailed it. Nailed it. And so there's two Natalies, and you're welcome for that. But when you have a person who does not verbalize, because it's really avoidant and they don't want to verbalize what their intent is, and now they're confused and they're not in a place where they're would be deemed competent to be able to make those medical decisions. What do you go with?
I went with two things. And the first thing was what I knew about how she had lived her life.
Okay.
And what was important to her. And through casual conversations, how I knew her. So the first thing I told my husband, we were getting dressed to go to the hospital. I said, I know two things. And this became very clear. And I don't know why. I said, I don't want her to be scared and I don't want her to be uncomfortable. She'd always been a very fearful person. And that's why the conversations about end of life and serious illness had not happened. Even when she was diagnosed with the cancer, she never discussed it with anybody. She had a small circle of retired teacher friends who literally dragged her to the attorney's office to get these documents done. Literally had to force her to do it. And then she never discussed anything with them, anything with anybody. So I told my husband those two things. That's my first instinct. I don't want her to be scared and I don't want her to be uncomfortable. And then the rest of the choices I made based on what I knew about hospice and healthcare. So what I tell people who tell me we never had these conversations, I don't know what to do. I always tell people, make decisions based on how they lived their lives. What was important, if it was a spiritual life, a faith journey, make that an important part of the care that you provide. If they were very opposed to medical care and dying in a hospital, make that part of the decision making. But look at who they were and how they lived their lives. For Betty, being safe was a big priority for her. And so we knew that wherever she was, whatever caregiving environment, she needed to feel safe. And she needed to be comfortable. So that's what we went with.
Hey, ladies, I need to interrupt for just a second to share about the Sisterhood membership. It's basically a sale every day. And the best part, it's free. Here's the details. We're partnering with our friends at Benefit Hub and other care partners to save you money. With over 200,000 participating companies across the US and abroad, you'll find discounts at your favorite local stores, huge savings on vacations, amazing deals on home, auto, and supplemental insurances, and everything in between. Go to confessionsofareluctantcaregiver.com to sign up, and then definitely tell your friends about it. They can join too. Trust me, there's a discount for everyone. And don't forget, it's free. Okay, back to confessing.
So after this initial crisis, where did the process go? Because that wasn't the only crisis that you had to get through. This was a 3-month process.
It was a little weird. The circumstances were very odd because she was in ICU in the hospital and the care was decent. The physician was not. He was horrible. He was loud and very abrupt. It was on a weekend. So of course we weren't dealing with a physician that knew her. It was whoever was out there. And he kept saying to me, she's moribund. She's moribund. And I knew what that meant because I work in healthcare. He did not know that I was a nurse. And I just looked at him and finally he raised his voice and he said, Mrs. out in the hall, right outside her room, she's dying. That's what that means. And I could feel a little blood vessel pop in my head. And I'm like, okay, that's fine. If she's dying, I want her to go to hospice. And he immediately left, never said another word to me, which was fine, because at that point, we were free to steer in a direction with a team that I knew would be better, communicate with us. So she was moved because she was symptomatic. She had some, what we call terminal agitation. She was agitated. She was moved to general inpatient hospice house, a hospice building, where it's just for hospice patients who are in a symptom crisis that can't be managed at home. And at that point, she didn't have a place to live. She had an apartment where she'd been living by herself, no caregiving available, no space for anything. We couldn't have even put a hospital bed in there. So, and she was pretty much actively dying at that point. So a few days later, she rallied, which was fantastic. But in the interim, we had been trying to figure out her finances. Finances were very tight. And she had an apartment that was costing, that was probably her biggest expense. So we cleaned out the apartment, and which was no small feat. Betty was a hoarder, and she had been for quite a while.
And that's your responsibility, right? Is that became your responsibility?
Yes, that was
Wow.
me and my husband and this wonderful team, this powerhouse of retired teachers, those ladies.
Wow.
Oh my gosh, go-getters, wonderful people. And
But let me just say, I'm going to interject as Natalie says, we're interrupting cows. During all of this emergency situation that it was in an envelope that you opened on the way to the hospital.
yes.
Were you, so it's you and your husband. Do you all have jobs? I know you have kids. So
Yes.
you have a life.
Oh my gosh, my husband, my kids were grown and, in college, but my husband has a full-time job that he works 12 to 14-hour days. And I was actually working a job where I traveled all the time. So I had to shut my calendar for a few weeks.
Wow.
And we worked from 6 a.m. until 10 p.m. to get the apartment cleaned out.
Okay.
Yeah,
There
we've
was,
done
there
that
was
before.
no other choice. Yes.
Yeah.
We needed the money. We needed to free that up. And then when she rallied and they said, she's no longer actively dying, I'm like, well,
Crap.
I knew how to do the hospice part. I
Yeah.
know how to do this. So then it was, okay, she can't stay here because this is a crisis management facility. She needs to go somewhere. We had closed her apartment. She no longer had a place to live. And I'm like, I was in complete uncharted waters, had no idea. So we found a personal care home. Thank goodness I had connections
Mm-hmm.
in the hospice community. I knew of these personal care homes. They're unlicensed places that are run in somebody's home. They usually have just a few patients or residents. And we found a woman. She's very warm. I had patients in her home before as a hospice nurse, and that's where Betty went to live.
Let me ask you this real quick. Moo, you're welcome for that. Is this paid, or because it's unlicensed? And I work in mental health, and I'm thinking the moment that you say unlicensed, I'm thinking not reimbursed. And so
absolutely.
is it? I'm assuming this is private pay.
Oh yeah, it was out of pocket.
And Betty was, of course, won the $1 billion last night, and so So she's got tight. So because at this point, I'm sitting here like, holy crap, because it's honestly you're like, what happens when the person is dying and you plan for them to die and they undie? And then you're
that
like,
for me
crap.
is wait a minute, what do I do now?
And are you thinking, did you
what
and
am I
your
supposed to
husband
do
have
with
a
her?
conversation where it's like, is Betty coming home with us? Did the conversation around is Betty coming to live with us ever happen?
Did I say that I wasn't that nice? That conversation never happened.
Okay,
that
good.
conversation never happened because we both had full-time jobs. I wasn't even in town Monday through Friday most of the time.
Yeah.
Wow.
So for us to be round-the-clock caregivers for her, for a bedbound person, there's no way that could not have happened.
Yeah.
We were not equipped to do that. And she did not have the finances, nor did we, to supply 24-hour caregiving services.
But does the system respond that fast? That's the bigger thing. So I think about because I know the system is not fast. You and I both know that government entities don't work super fast.
True.
And so I'm thinking about, at this point, I'm assuming Betty's been on Medicaid because she's low income.
She did not have Medicaid. No.
Oh, she didn't even have Medicaid.
Medicare. No.
So she's the retired poor, but doesn't meet enough to meet Medicaid criteria.
Exactly.
And
so in Texas, Medicaid will cover room and board in a nursing home.
Yeah.
Medicare, which is a federal
Absolutely
program, does not cover that at all.
Yep.
Right.
So we were flying by the seat of our pants, looking at her finances and trying not to devastate our finances at the same time. Which is, anybody who's caregiving, who's listening to this, will know the finances of the caregiver can become an issue. A lot of times the caree, the person who's got the illness, whatever debilitating illness and situation they have, they've blown through their finances.
Absolutely.
And it's very easy for a caregiver to get sucked into that. So we really tried to be smart about, we knew Betty was never going to drive again. We sold her car. But there are a lot of legal things that have to happen to be able to do all of that.
Oh, yeah.
Oh, yes.
Yeah. So the hospital was very fast. I'll tell you that, Natalie.
Okay.
They were very fast. They were more than happy to get her out. More than happy to get her
Of
out.
course they were.
Yes.
Of course they were, because she's not getting reimbursed anymore. She didn't meet medical necessity.
Right.
Yeah.
They knew she was dying. They didn't really want the death stats on their on their records, right? That's part of what a hospice doesn't like, a hospital doesn't like.
Absolutely.
The hospice was very generous. So they took her in, and because I was traveling and we were having to look for a caregiving situation for her, an environment, they were very generous about, they probably gave us more days there than they should have.
Yeah.
But let me ask you this, and because I don't know the answer, is hospice paid for by Medicare?
Yes.
Okay. So
Yes.
that's important. So hospice is paid for by Medicare, and that includes community-based hospice and residential hospice. And so for folks, when I say residential hospice, that's literally someone going into a facility. That's where our grandmother passed, is she was end of life. And I think she was there maybe a week.
Maybe, yeah.
Maybe
No,
10 days max. I don't even think it was a week, that she went into a residential hospice, which was like, the most beautiful therapeutic place ever. If you're going to die.
For our entire family.
For our entire family.
It really was.
It was even more for us than it was for her, because she was just unaware.
That's where Betty was when she discharged from the hospital. She was in a hospice facility like that. Yeah. And I was so grateful because I knew they knew exactly what to do. They knew what our goals were. She was a DNR. She never became aware enough of her illness to make decisions with me. They did a mini mental exam on her to find out. And she talked about a lot of distressing stuff. She talked about her mother. She was waiting for her mother. She was very attached to her parents.
Yeah.
She was pretty much raised as an only child. Yeah. She talked about her mother coming to get her. She had some distress, and the hospice knew how to take care of her. They were very generous with the care, but also with the time that they allowed her to stay there.
Yeah.
And I had the time, because it took time to search, and I was not sleeping well. I got very snappish, very, very ugly. I probably still owe my mother-in-law several apologies, and my husband too. But we worked as a team to figure this out, and were able to place her. I don't want to say that. We were able to find another living environment for her. I don't like to say place, because it makes it sound like you're putting a cup on a shelf. People are not objects. So we found this living environment for her. But the entire time I was second guessing myself, and I was angry. I was angry with Betty because she had not had these conversations. I was equally angry at myself. Why did we get those papers and I never at least tried to have a conversation with her about her end of life wishes? What kind of hospice nurse does that?
Once Betty, once she got out of the hospice and there was kind of that bounce back time, did you ever have a chance to talk to Betty? Did you all ever talk about it, or was she not in the mental state to have a conversation, or did you just not broach the topic?
We did have one conversation. It was very limited. They had done a mini mental on her, and they felt like it was the social worker had done that. Hospice social workers can do that. And they felt like she, at least in that moment, could have an organized conversation with me. And I needed to talk to her about one of the benefits she had through her retirement program with the state, about using that for funeral expenses. And so I approached the topic with her, had a conversation with her, and I have to admit that I cried through the whole conversation. And she said, yes, that was fine. We kept it very minimal. I didn't know what she could handle, because we had not had any in-depth conversations, and very little of it reality-based. And when we got done, when I finished talking with her about that, I said, thank you. I just really needed to know what to do. She asked when her mom was coming to get her. Her mother had been dead for years. And I realized I'm going to make this decision by myself. So we did.
That had to feel very isolating, lonely, overwhelming, like insert all the bad words, right? Because you are the sole person named. And even though you could go and you could say to your mother-in-law, you could go to your husband, you could go to any number of people, the final decision is on you, because doesn't have the capacity to make it.
Right.
And so I think for listeners, it sounds like, do a solid for your loved one who you have named as your medical power of attorney. Make the decision while you're aware, even when the decision's hard, and know that you can change the documents. I mean, our grandmother was really big about changing her will when she got mad at our mom or any of the children. And so we did love that. Too. And she would tell you, you make her mad. She's like, I'm going to go change the will. And you're like, okay, you go spend that money. And with the grandchildren, we were never at risk. She never threatened us. It was great. And so, but I think, that's a burden. That's a burden to carry when, especially, Helen, do you think it's any heavier not being because you're essentially, it's almost like fictive kin. You're a stranger to her. You know her. You're familiar with her, but you're not her bestie. Not like
you're an acquaintance.
You're an acquaintance. Right. Thank you, Jay.
Yeah.
Do you think it's harder? Do you think it's potentially harder to make that decision and the questioning, you're second guessing yourself with an acquaintance versus somebody that is a loved one, like parent, whatnot?
I think there are challenges on both sides of that. From my experience with Betty, because I had so many years in healthcare, I could run with it. I don't want to say interference. I didn't have anybody I had to debate. I didn't have to make decisions that I didn't agree with.
Yeah.
Which is a lot of times what a medical power of attorney has to do, right? You're acting on that person's decisions and wishes, even though you may or may not agree with them.
Yeah.
So I didn't have that particular part of the caregiving burden, which is a real thing, right?
Yeah.
But if it was a loved one that you knew very well, how agonizing is that? Because of the emotional, the grief. I don't think, this is going to sound callous probably, I don't think I had the grief investment because I wasn't as close to Betty.
Yeah.
If I had been closer to her, it would have been different.
Yeah.
It grieved me. That's, it made me very sad. I hated to see her suffering. The quality of life she had, what we call anhedonia, which means she got no pleasure from things, from her life. There was no quality of life. And that was very grievous to me. And I wanted her to be comfortable. But if it had been someone that I had, known my whole life, my mother, one of my siblings, that would be different, I think. Yeah. So I think both ways have their challenge. Caregiving burden is a very real thing.
Yeah.
You
said you were, first of all, it had some physical impacts. You said you weren't sleeping.
Right.
But you were angry too. Tell me about that, like physical impacts. And you were, I'm going to use the word hateful because Lord knows I get hateful. And that's a fair word.
I have been hateful.
And with my mom, we get hateful with one another when we're trying to make decisions, and they're not life and death decisions. It's mom can't have her phone anymore. We're not spending $90 a month. We got to get rid of this. And then I'm like, but she needs her phone. And then I get a lot of hate emails and texts like we're closing that down. So
I mean, when she sends it to the dry cleaners or to the laundry, that just made nursing care sound really bougie. Yeah. Like people just send their clothes to the dry cleaners. And guess what? They're not getting dry cleaned. You're lucky if they come back, actually. But she sends her phone to get washed every now and then. So that's been super awesome. And then you can't talk to her for a week.
Yeah.
So and I don't know if that's a blessing or a curse. Keep going, Jay.
Yes. So tell me about that. Tell me about the physical impact on you, like physical, but then also tell me about that anger. Tell me about the frustration.
Well, the sleeping issue is huge, right? Because that's such a pivotal piece of self-care.
Yeah.
Right. Everything hinges on getting good sleep. Well, I was short on sleep. I would wake up in the middle of the night and I would, send myself a text, look for Betty's driver's license.
Oh my gosh.
See, make sure we shred her social security card, things like that. But the anger issues, I became very short-tempered, especially when I'm tired. I don't do well without sleep.
Yeah.
And I would be sitting in the middle of her apartment. Here's this overwhelming, we would open dresser drawers and it would be full of grocery receipts and medical bills and invoices. And in the middle of that, I would find her mother's birth certificate. Things like that, where we couldn't just say, oh, this is all garbage and we put it in a bag and dump it. We were looking for certain things. Like we knew she had a passport. We knew there was a safe deposit box, but we couldn't find any of that stuff. And we couldn't just do a big sweep and throw out stuff. So when my mother-in-law, who had been helping Betty financially and doing things for her, would go into an explanation of something that was very long-winded, I would tell her, I just don't have time to listen to all of that. Can you just give me the answer?
Yeah.
And it was in a way very direct, and I was communicating what I needed. But I think I did that numerous times, and I'm sure it wasn't a nice way to do it. But at that point, I just did not have the bandwidth emotionally, mentally, with my energy, physical energy that I had to take all that in. I don't care what happened 15 years ago when we have 48 hours left to clean out this apartment. And I need to know where her safety deposit box key is.
Yeah. But that's okay. Because sometimes I get a little frustrated as well. I'm like, shut it down. I just need a yes or no.
Yeah.
Exactly. And that was really difficult for me because the retired teacher ladies, this group that was helping, they helped clean out the apartment. They had known Betty for 30 years. And so sometimes there was a little, tiptoeing through the daisies, and I could not take all that in. That was what it was. It wasn't just that I didn't need that information. I could not take that in.
Yeah.
There wasn't enough space on the hard drive of my brain, what I was having to access at the moment, to be able to hold on to that. If it wasn't useful, please don't give it to me to hold.
Yeah.
And maybe that's the caregiving message. Don't try to take on things that you don't need. It's okay to tell people, I really appreciate what you're trying to contribute. I just don't have the energy to hold that with you right now.
Oh, wow.
That's
the
great.
money right there. Honestly, Helen, that's the money, because that's the advice, because there's so many people. Somebody texted me yesterday and said, hey, I have a friend of mine who's caring for her husband, and he's going to pass, and I really want to help her. But I've been thinking about what you guys do. And, I wanted, before I go and ask what you need, ask them what they need. What would you advise? And I'm like, well, you might offer suggestions and then say, do any of these things help you? Do any of these things? And as opposed to going, because lots of people have opinions, and I'm sure those well-meaning individual ladies are all reminiscing. And honestly, I'd have been like, shut it down. I got a task to do. If we don't get this stuff out of this apartment, you're thinking about late fees that you're going to get penalized with. Because we had to do the same thing with our mom, with her apartment.
Yeah.
Like I remember I skipped my 25th class year reunion. I know you're shocked because I don't look that old, but I was Doogie Howser and I graduated when I was 10. And so I remember, because I did not have the emotional bandwidth to go and be friendly to people from 25 years earlier. I was so like pissed at my mom for having all this crap in her house. And JJ's all like, and this was when we were nicer. And JJ was like, oh, that is so sweet. Do we think we should keep that? And I'm like, no, trash it. Nobody cares about that. Like the awards and all the crap. I'm like, nobody cares about that. I'm even throwing my awards away now. Like I'm not even there. And I'm like, no, I don't want anyone to have to throw this crap away.
Right.
So
That's sifting through that stuff. And I'm a decision maker. Once I make the decision, it's done. And my husband is a deliberator. He's a more thoughtful person. He would say, yes, we could do that. And so in my mind, that was a yes, we just go. In his mind, then the next thing he says is, or we don't have to.
Oh,
and I'm like, gouge somebody's eyes out, and it might not be mine. So we are going to. So I'm just like, I'm the decision maker. I don't have time. And then the flip side of that was with the medical decision stuff. It was like when you go to a wedding, and the groom throws the garter, and none of the single guys want to catch it, and so they let it drop to the ground. Everybody's standing back, like, not me. I don't want to do this. That's what some of the medical decisions were like. They were all like, they backed off. You're the one who knows all of the medical stuff. You're the hospice nurse. This is you.
So do you think that is one of the reasons why, when you first met Helen, or you had your history with Helen, is that why you were drafted into this position, Helen, is
Yeah.
because of your experience. She thought, well, she's a nurse. She's a hospice nurse.
Absolutely. Absolutely.
So what happens, Helen, because I'm all about free will. What if you had said, no, I don't want to be medical power of attorney? Like, I reject that. Like, does the state of, she was Texas, right? Because you all, I'm assuming you're on the state line.
Yes.
Do you get to reject that? Or is the state of Texas say, good try? That's cute.
Oh, no, no, the state doesn't. Texas would probably like to think they have that much authority, but no, they don't.
They do feel that way, don't
the
they?
bad thing is basically I would have to abandon, refuse to do it. So what it says on most medical power of attorneys, you have a first agent, and if this agent is unwilling or unable
Right.
to act, then the second agent's there. Well, there was no second agent. Betty had no children. She had half siblings. I think maybe one of them was still alive. She had cousins that she had not spoken to in years. And I did get in touch with all of them. And I was concerned that there would be some pushback. Why are you doing this? What do you have to gain from it? And maybe I should be the medical power of attorney. Nobody. Absolutely no. It was the garter lying on the floor with all the single guys backing away from it.
Wow.
Yeah, it's like the finger on the nose, like, not it.
Yeah, this is not
right.
mine.
Everybody's like,
no,
not it.
Right.
So
And in a way, that was a relief
yeah.
because I could act with autonomy, and I felt pretty secure about managing a patient who was terminally ill because I've done it so many times, just not in a personal way.
Yeah.
And I think that made it easier. But if I had said, no, I'm unable to do this, or I'm unwilling to do it,
right.
the state would have had to find a relative, or they would have had to appoint somebody, and it would have been she would have been dead before they figured it out.
Yeah.
Yeah.
So how do you think that has impacted from that point? I'm assuming that you have all of your powers of attorney and all of your wishes
how does this
laid out, Helen.
happen?
What did it do? Has anyone else dropped an
what
envelope
did you
off at your
learn from
house?
it?
Has anyone else brought you an envelope, Helen?
Well, first of all, no. My mother has made me her medical power of attorney, and I've had that for years. I'm good with that. So the title of your show is Confessions, right?
Let's have it.
Let's do it.
I do not have all of my advance directives done.
Same.
Yeah. I don't trust Emily's kids. I'm not going to lie to you. I trust Owen. I don't know about those other twins. They'll just follow what Owen does anyway.
I have two girls, and I call them the Jokers. And my husband is a very easygoing guy, right? I have nobody in my family, extended or immediate, that has any healthcare experience at all. Nobody works in the healthcare field, which scares me horribly. So I have one daughter who's a firefighter, who will not discuss cremation or anything like that, human composting, which is what I want to do. She will have me stuffed, and either that or she'll keep me on a ventilator until the machine breaks or the power goes out. My other daughter just thinks I'm going to live forever. So I'm not sure the Jokers are the best people. And my husband is a passive person who will go along with whatever. And I know enough to know exactly what I want. Yeah. So it'll be on me, right? It'll be my bad if I don't put it in writing. But I definitely am not prepared.
So currently planned ignoring. Okay, because I know we have to go to sister questions. But this is so good.
Helen, don't send me the envelope, but I will make sure about the composting thing.
JJ will do it.
Yes.
Helen, JJ will do it.
Do not send me an envelope.
Put JJ's name down. She's really good too. She's good. Like
just give me your address, JJ. Just give me your address.
JJ's address is Big Pine Key.
I'm the only one there.
So yeah, honestly, JJ's in charge. That's the standard answer for the Elliott sisters.
Yeah.
JJ's in charge. Okay, so I want to go to sister questions, because I really think this is important. And but I will say this: we are going to be on guest on Helen's show, so you're going to get more of Helen, because we're going to do that. We'll do that in September, and we'll keep you guys posted when we go on, because we're just going to have big fun. So we're going to keep talking to Helen, but Miss Emmy, because you have dominated
Yes.
the conversation the whole time. What is your
Can't-
question for Helen?
Poor Helen. You can't get a word in with these two. But I'm listening to your whole, what happened. And I'm like, how did Helen have the strength to get through this? Like, it's different when you're working, you can separate yourself from it. But when this is so personal, like, what was your rock? What got you through?
Good question.
My biggest foundational rock was my husband, because he was right in there. I mean, this was a person we called Aunt Betty, right? He'd known her his entire life. My kids had known her. He was awesome. And the fact that he was actually designated as her financial person made us a great team.
Yeah.
Made us a great team. Then I had all these hospice colleagues.
Yeah.
I placed her with a hospice. I hired a hospice that I had worked for. I knew the facility. I knew the team. I knew the nurse that saw her as an outpatient patient. And these were people that knew me. They knew I traveled for work. They knew that I wanted to be informed and how and when. And so we surrounded ourselves with this healthcare team that was amazing. And then her system of friends, these retired teachers, the bossiest go-getters ever, they made a calendar of who would stay over the night with her. And they told me to go home. Totally, they put on their bossy pants. They were awesome. So that's how I got through the whole thing.
Wow, that's impressive. And I think that everybody had their role and responsibility.
Yeah.
All right, Jay.
The Heart of Hospice is your podcast. The name, what is that about? Like, what is that? It's your podcast and your business. So just tell me about that. What brought you to that?
The Heart of Hospice podcast was born out of having people say to me so many times, I wish we had known about this sooner, which is heartbreaking for people who work in end-of-life care to know that we could have helped sooner and earlier. We wanted to provide a resource that would be free, accessible whenever, because whether you're a personal caregiver or a professional caregiver, your time is limited, your mental bandwidth, your energy is limited. And so the podcast came from that. And we've got content, anything related to serious illness and end-of-life care.
Yeah.
Oh, I love that. And it's been on for 7 years. All right. So I'm pushing because I got about a minute.
Okay, I can do it.
What is your favorite guilty pleasure?
Oh, snap. Dark chocolate.
Yes.
Yes. That's an easy one.
Boom. Always. All right.
We got to get a supplier for dark chocolate.
No
There's a lot of people.
We need a sponsor. Hello, sponsors. And so
dark
let's
chocolate.
just start randomly naming Ghirardelli brownies in a cast iron skillet. So Helen, we love you. You are definitely, and you are a sister. Yeah. And thank you so much to come on and share so much of your story and what you've learned from it. And even confessing to the fact of this happened to me and I still haven't dealt with it because there's a reason why. There's the why's behind there. And I'm not going to ask, but the why is there. But if you take one thing away from this today, you will be better for your planning. So guys, thank you so much. Helen, thank you for being with us. And until we confess again, we will see you soon. Thanks everybody.
Bye.
Thank you.
Bye.